And Elizabeth, you're a doctor, right? I am not the perfect Asian daughter because I am not a doctor or a lawyer.
I haven't had any stories of people shoving things up the butt that shouldn't be up there.
Welcome back to another episode of the Captain Bagrat podcast, where we're on a mission to fight boring news about Asia and Australia. It's a tough job, but someone's got to do it. As always, we're recording from Downtown Chinatown, and today I welcome Elizabeth.
Hey everyone.
Hey. And Elizabeth, you're a doctor, right?
As of Tuesday, scary thought.
You're going to be operating on me one day, probably.
Yeah, well, surgery's not really my kind of thing, but maybe we'll see.
And there's another thing. I don't know, but a lot of the listeners might know that I am not the perfect Asian daughter because I am not a doctor or a lawyer. So I think you're the perfect white Asian daughter.
I don't know. My parents are pretty disappointed I chose medicine.
Oh, really?
Yeah.
So they're not like white tiger parents?
My father's defence.
Okay.
In fact, my entire family is defence going back like 3 generations.
Oh, wow. That's quite a lineage to live up to.
Yeah. And when I didn't choose to go to the Australian Defence Force Academy, it was not a good shock. Hey, Mum and Dad, I got into medicine. So you're not going to ADFA? I got into medicine.
You're not serving the nation.
You're not going to ADFA. Well, no, ADFA doesn't do medicine, Mum and Dad. ADFA! But medicine.
but surely ADFA can sponsor a doctor, right?
So the Defence Force can sponsor doctors once you're partway through your training.
Okay.
But I guess the real appeal for ADFA was you start immediately as an officer and you get a free university education, which medicine is not free at all.
Medicine's very expensive, I hear.
If you're an international student or you don't have a CSP place, absolutely. Mm-hmm. If you have a Commonwealth supported place, then your HECS is about $11,000 a year.
Oh, that's not too bad.
Yeah.
$11,000 a year. That's normal.
Yeah, as an undergraduate, it's the same price as as engineering or law.
Okay.
So I've got
the same.
$66,000 under my belt, but I start with a guaranteed job at $69,000. So
yeah, and they only tax you, or you have to pay back the HECS or whatever you call it these days. Only once you have a job,
yes.
Right? Yeah, so it'll be fine. Everyone's got this. This is a good debt to have.
Well, considering it's interest free, it's probably the best debt you can have.
I know. Talk about mortgages, eh?
Oh yeah.
So then how long does it take to become a doctor? Because to become a fully fledged doctor, it takes a long time, I hear.
Yeah, so the fastest way to become a doctor is to finish high school, go straight into a 5-year undergraduate program.
Yeah.
Do your 2 years as an intern and resident.
Yeah.
And then go for GP training, and all up that's 9 years.
That's a really long time of your life.
Yep.
Yeah, considering you do a kindergarten all the way through to year 12.
Yep.
And then you do another 9 years.
Yep.
Oh, wow.
And if you want to be a surgeon, the training's longer. It's like 5 or 6 years once you're on the training program, but you'll spend 4 or 5 years just trying to get onto the program.
Wow.
Yeah.
That's a lot of dedication.
That is a lot of dedication. The surgeons who get onto the program are people who light up when they're operating, because there's no way you keep trying to get on and do their stupid hours unless surgery was your life.
Wow. So no wonder, a lot of surgeons and a lot of doctors, in the sort of emergency and the really high intensity areas don't really have a life.
Yeah.
All I hear about is like, oh, no, I'm always at work.
Yeah. Well, of course, we've got the case of Dr. Kadota from last year, the Bankstown hand surgery registrar, who had to quit after having severe overworking and bullying and harassment issues.
Oh, no.
I guess the thing that's most sad about that is not that it seriously screwed up an individual, but when I was reading the story, I was not surprised.
Okay.
I could totally see how that would happen. And the fact that I'm not surprised by such a bad outcome says we've got something really seriously wrong in medicine.
So is this because there's a shortage of doctors? Because like in the news, I'm always hearing, people saying we need more hospitals, we need more beds, we need more doctors. Then why are we still, the hospital's being built?
Yeah.
And I keep seeing the government's providing more money, funding, but then somehow we're still not resolving this.
Yeah. So there's a couple of issues there. One is funding. Doctors are expensive. Nurses are expensive.
Very, yes. Machines are also expensive.
Oh, yeah. medicines like babies, weddings, and fly fishing, you put that tag on and it's 5 times the price. So it's expensive to get the equipment we need. It's expensive to hire the people who have there. But we also have a bottleneck of training. So over the last 10, 15 years, medical student numbers have doubled.
Which is good.
Yeah, you'd expect to get more doctors, and we're getting more junior doctors.
Okay.
But you can't practice completely independently until you've completely finished your training. And what's happening is we have too many junior doctors who still need supervision that can't get onto the training program to become a fully fledged doctor.
Because in the training program, they always have to go under a mentor in a way.
We just don't have enough positions of the different training programs.
Oh, that's really disheartening.
Yeah.
Oh, no.
There's also a distribution issue where we've got a lot of doctors in cities, but we desperately need them in the bush, and people just don't want to go rural.
Okay. But there are a lot of perks to go rural, right? Because you're about to go to Wagga.
Yeah. I'm really looking forward to it. So I'll be spending the next 2 years at Wagga Base Hospital, which is going to be fabulous.
Excellent.
Yeah. So some of the perks of going rural is once you're fully fledged, you get paid a lot more. So, for example, a GP in a city might bulk bill.
Yeah.
A GP rurally does not bulk bill, or they only bulk bill certain patients.
Okay.
So already you're going to be getting more income from there.
All right.
Hospitals will pay you more because it's difficult to attract doctors out there.
Yeah, because there's not much happening in a town compared to a city where you've got, more nightlife and more options, I guess.
Yeah. Well, I guess the issue is what people count as rural.
Yeah.
So I grew up in Whoop Whoop, which is a real place, I promise.
Whoop Whoop.
It's actually
called a very Australian way of saying it.
It's actually
middle of nowhere.
Yeah. It's actually called Boro, but we're talking no mains power, no mains sewerage, no mains water, single dirt road that's 20 k's and it's got 20 families on it.
This is caveman.
Yeah, this is caveman.
This is total caveman.
So when people say they don't want to go to Wagga, which is a major university town that has a mire and is...
Oh, that's actually not bad.
Yeah, as an idea of size of town, it has a mire. It has 2 hospitals and it's 2 hours from Canberra.
Which is a capital city, not like Sydney, but it has all the essentials of an art gallery and everything else you might need.
Yeah, well, people are like, that's way too rural. But that's also the same people, if I'm guessing from your tone, also you, who think Canberra is rural.
Look, I'm actually from Canberra. I lived there pretty much all my life. So it's a bush capital. That's what it is. It's better now.
Yeah, rural doesn't always have to mean that you're the only doctor for 1,000 kilometres away. It doesn't mean they don't have a supermarket.
Just not a beach, like in Sydney.
Yeah, so I guess there's a type of rural to fit everyone, but we really need it. Even if people just fly in and fly out, we need those services.
Definitely. And I also understand that being able to work in the rural areas, you will have more opportunity to grow as a doctor.
So when you're in rural hospitals, it can be variable. Some days you'll be completely smashed and other days you'll have it pretty light and easy. But the doctors there care more. They give more teaching. They give up their own time to teach you, and they also give you more responsibility.
Oh, which is good because you need to learn on the job, right?
So when I was in Catherine Hospital in the Northern Territory, one of our junior doctors did a lumbar puncture, which is a needle into the spine to get fluid there so we can see if there's an infection in the brain.
Yeah.
If you're in an inner city hospital, that would probably be done by a registrar because there's just not enough time to teach a junior doctor how to do that.
Okay. No, that's really good because, the more practice you get, the better you will be with any occupation, any skill set. Yeah, so I think you chose well to go rural and just, lift up your game. And next thing you know, you'll be on a TV show, be the equivalent of the Bondi vet. You'll be Wagga doc.
Next TV show, I'm going to be the farmer wants a wife and I'll be the farmer. So it'll probably be what? Farmer wants a husband? We'll see.
Farmer wants a hubby? Yeah, I can't see why not.
Yeah, they can come see my miniature cows.
That's right, Channel 10, get onto that. And so what made you want to be a doctor? There's so many other things you could do.
Yeah.
Why?
So some people talk about this passion they've had since their loved one was in hospital and the doctors did such an amazing job, and some people were like, I just want to help him and I can't think of anything more. And for me it was, I thought I wanted to be a pharmacologist, so I'd person making new drugs.
Yeah.
Thought I'd have an amazing impact, and then I realised I hate doing chemistry practicals. I love the theory. I didn't like doing it.
Yeah.
I wanted other people to do it. So I'm like, okay, scrap the pharmacology thing. So then I thought, okay, well, I want to help people and my grades are good enough. You know what? Let's just apply for medicine. I won't get in, but I can say I applied.
Yeah.
And, well, I got in.
And you're like, I'd better accept, I guess.
Yeah, well, I didn't have any other uni programs I really wanted to do, so let's go do medicine.
And do you get queasy when you see blood, or do you have anything that would hold you back a little?
So I have a couple of disabilities, as you do. So
we all have disabilities.
Yeah, I have a habit of fainting.
Just like me, yes.
Yep.
Sight of blood, or when I see a needle going and I get all queasy.
Well, for me, it's not that. The only things related to blood is when I was donating blood one time, because you've got a big-ass needle in your arm and they're stealing your blood.
Yeah.
And the first time I ever went to theatre,
which is not the acting theatre on a stage.
That would be the operating theatre.
Okay.
Yep. So I'd just scrubbed up, so that's washing my hands for 5 minutes under the watchful gaze of a nurse, because God help you if you touch something. I'd then got it into the gown and I had a mask on, which means you can't really breathe oxygen very well.
How are you supposed to operate if you can't breathe?
So I'm all gowned, I'm all sterile, I'm not allowed to touch anything.
Yeah. So hands up in the air like this?
Exactly.
All right.
In a prayer position just in front of me. And I'm standing looking over the surgeon's shoulders for about 2 minutes. Yeah, it's yucky because they're making a fistula for dialysis.
What's that? What's a fistula?
So that's when you get the artery and the vein and you kind of join them together. So you've got a really, really big blood vessel.
Okay.
And it's so cool because if you put your fingers on it, it kind of thrums like you'd imagine a battery would.
Yeah.
So they were making one of those so this patient could have dialysis later for bad kidneys. And I couldn't breathe. So I took a couple of steps away. I went to the corner. I tried taking off my gowns because I can't touch anything whilst I'm sterile.
Yeah.
And next thing I know, I'm waking up in ED because I've passed out. They've rushed me to the resuscitation bay, which, in case you were wondering, that's where car crash victims go. Because my heart rate got down to 14 beats per minute.
You're
which
literally a zombie.
means I'm super fit, right? Super fit or half dead. Clearly the anaesthetist in the operating theatre thought I was half dead.
Oh, no.
Kept giving me all these drugs. They're like, we can't find a blood pressure. Probably because my heart rate's so damn low.
Oh, no.
And during this whole thing, our patient was awake.
Watching this poor med student.
Exactly. So the surgeons kept operating because there's not much they can do.
Yeah.
And the poor patient's just stuck. It was like, I'm supposed to be the star of the show, and here's this damn med student taking it away.
And you're like, oh, I guess it was a bit of drama for me today.
Yeah.
And how did you feel when you woke up? You're like, oh my God, I can't believe I fainted.
Well, I've been fainting on and off for 10 years. So I guess it was more disappointing because my team was very good at keeping me out of theatre for the rest of that rotation.
Oh, no.
So I didn't get the experience I needed, but I've caught up since then.
Oh, that's good.
Yeah.
You being able to control your fainting for a little bit or just a different area.
Yeah, it doesn't, I can't really control it. It just happens.
Yeah.
But luckily it doesn't happen often enough to have me kicked out of medicine.
Well, I hope it only improves as,
Yes.
The more, the stronger you get, the less fainting you do, the stronger you get and you get through it. So did anything prepare you for medicine? So obviously you would have had to study a lot, by reading books and things like that. Did you, again, a situation where like, whoa, they did not teach me that in the books?
Yeah, so I was in the birthing suite when I was on an obstetrics rotation, which is the doctors who look after the birthing process. And in the birthing suite, that stuff's just... Some of the midwives talk about the miracle of life.
Which is holding the baby in your bare hands, right?
And just like, wow, this woman's just created a whole new life. She's like a goddess. She's like femininity personified. And I'm just like, the woman just pooed whilst the baby pooed as the baby was coming out. And like completely normal. You're doing a lot of pushing there and you're not just pushing a baby out. But
pushing everything else from down there out.
And the midwives just wipe it away. We don't tell the woman because she'd get really embarrassed. And It's medicine. I've seen so much worse. But,
oh, wow. What's so much worse?
So probably the grossest thing I've seen is we had an elderly gentleman who had to have a catheter put in. So that's a tube down the penis to the bladder to take urine out.
That sounds really painful.
Yeah, well, putting things down urethras is not comfortable for males or females, but we have to use a bigger size for males, so it hurts more.
Oh my God, I'm so glad I'm not a male.
Yeah, so he was already in pain. The reason we had to put it in was because his bladder was filling up with urine and it couldn't come out.
Yeah.
So imagine when you have to desperately go to the bathroom, imagine you've been feeling like that for hours and it just gets worse.
Oh my God.
So he was delirious with pain, which is what happened with our older patients.
Do you guys give him some drugs to relieve the pain? Or?
Yeah, so we were giving drugs, but the best way to fix it is to get the catheter in to take the urine out.
Yeah,
because
it's true.
Fixing the problem is the best pain relief.
Instead of like having a burst or something.
Yeah. Which I haven't heard of, but I always have in the back of my mind that might happen. Yeah, just pop like a balloon. Anyway, we were getting all our equipment set up, and the reason the urine couldn't come out was because he had clots.
Yeah.
So he's just there pulling these blood clots out of his penis.
Oh, lovely.
Yeah.
Yeah, out of the catheter, right?
No, we hadn't gotten the catheter in. So he's just holding his penis in one hand and pulling the clots out with the other hand. And then he kind of like held them and wiggled them and said, look at this. And I'm like, that's so nice, sir. Let us just get our stuff ready and we'll fix that problem for you.
Oh my God. Because I'm imagining the clot's kind of like a booger but red.
Yeah, so before I went into medicine, I thought clots were scabs, hard, crusty.
Yeah.
And then I got into medicine and they're more like a jelly substance. So a long red booger is pretty much perfect, except by long, I mean the length of my hand.
Wow, that is gross.
Yeah. Like he was delirious with the pain but it doesn't change that it's pretty gross.
Oh my God, I'm so happy I'm not a guy.
Well, yeah. Instead, we have the beauties of childbirth. Aren't we lucky?
Pushing that out. Oh my God. A tiny hole with a big baby's head.
Yep.
Or whatever. Sometimes legs come out, right?
Yeah, and when things go wrong, they go wrong fast.
Okay. So I want to hear this now.
The first birth that I was involved with ended up in the operating theatre unexpectedly.
Okay.
For something that we call a cord presentation.
A what?
A cord presentation.
So CORD?
Yeah.
Okay.
So that's when the umbilical cord, so what attaches the baby to the placenta and gives it all its nutrients and oxygen.
Yes, and the Scientologists, they sometimes eat the placenta afterwards.
Animals do it, it's full of nutrients.
Okay.
That cord gets trapped between the baby's head and the pelvis. So what's happening is you've got this squishy cord that's getting jammed with every contraction with the baby's head coming down.
Oh.
And what that means is the baby is suffocating. They're not getting nutrients. They're not getting oxygen. Yeah. It's not wrapped around the neck. It's just their air supply, their air line is being blocked off.
Oh, gosh.
So when that happens, this poor woman, you basically have to put your fingers into the vagina, push the baby's head off it with 2 fingers with the cord in between, and then we rush them to the operating theatre.
Oh my God.
To have a cesarean section, and the midwife's fingers stay in there until the baby is out, because otherwise the baby will die.
Oh my God. That's intense.
Yeah, that was my introduction to the birthing sweat, and I was terrified after that.
Oh my God, I'm terrified right now. I'm like, I don't think I want to give a baby. I don't think I want to get pregnant.
Yeah, well, the good thing is when you birth in Australia, I guess it's good or bad, we don't really have home births in Australia.
Yeah.
Which a lot of other countries have it, and I feel like a lot of women would prefer it. But when you're in the hospital, we hook you up to monitoring. So we've moved very far away from natural birthing.
Yeah.
But you're hooked up to monitoring, so if that starts to happen to the baby, the monitors go off, we go in, we see what's happening.
Yeah.
In this case, the midwife did a vaginal examination, felt what was happening, got me to call for help, and within 10 minutes, the baby was out.
Because if this scenario happened when you were doing a home birthing, then they probably wouldn't have been able to know the situation until
so
in a stillbirth. Is that what they're called?
So if you picked it up early enough, the midwife, again, would just keep the baby's head off the cord, call for an ambulance, get them into a cesarean section immediately.
Wow. So maybe should go to hospitals, people, if you're having a birth. Now, I have a friend who also became a doctor, and he worked in an emergency room during his rotations. And some of the stories that he told me were pretty intense. Yeah. He told me stories about things getting stuck, people stuck up in places where it shouldn't get stuck up. He also told me stories about a lot of druggies who come in and they're really violent, so they have to lock them in an isolated room. Is that what it's called?
Yeah, we have isolation rooms.
Isolation rooms, yeah. And from that experience, he then decided that he would just become a clinical psychologist instead.
Well, we certainly need more psychiatrists, so there's going to be plenty of work for him.
He seems to enjoy that more so.
Yeah. So reading all the things on the internet about how to get you prepared for the emergency department or ED, I basically got the impression that I should be expecting lots of strange things stuck up people's butts.
That's right.
Yep. And shootings and stabbings.
Yes. Did you get that?
Well, I got one stabbing.
Oh my God.
Yeah. Which was done with a butter knife and it wasn't particularly deep. The patient was completely fine.
Oh, all right.
Yeah, so not a very exciting
Maybe it was
story.
A kinky incident that they were having.
Yeah, who knows. But I feel really disappointed. I haven't had any stories of people shoving things up the butt that shouldn't be up there.
Okay.
Hasn't been there whilst I've been working, hasn't even been there that day, and the other doctors have told me about it. I feel like I've really missed out.
I think you have. What about all the other grad students who were rotating? Did they get to see things like that?
Well, if they did, they didn't tell me.
Oh, maybe it was a nice hospital you were at.
Yeah, well, the closest we learn about is people swallowing razor blades, so...
People do that?
People do that.
Oh, I thought it was just a magic trick that...
Nope.
Oh, okay. That's a bit dangerous.
Oh, yeah, that's why they do it.
And have you had an incident or just heard stories?
Yeah, so we've had... sometimes it's a collection of, young children swallowing things they shouldn't.
Okay.
Usually not the razor blades because you've got to separate it from the razor head. But batteries are really dangerous, particularly those little circle ones.
Okay.
Because the acid that makes the battery run leaks out. And then the acid burns all the inside of your esophagus and you can't eat.
That's right. Always before Christmas, people say, watch out for your kids because if they're playing with batteries on toys.
Yep.
All right.
They will swallow them because that's what kids do.
Yeah.
And then we will have to do a surgery to get it out.
Wow. As in completely cut them open? Or?
So we try to avoid the cutting open because there's complications with everything. So we'll try and do what's known as a scope, which is putting a long camera down, and then we get a little pair of grippy things to pull it out. Yeah. It really depends on where the button is.
Okay, that sounds intense.
Yeah. Well, when you consider that the age of kids who do that is 2 or 3, it's really intense.
Yeah. Wow. Any other stories that's less sad?
Yeah.
Or...
well, I've got a miscarriage story, but that's really sad.
Yeah.
So,
next.
Yep. So the next one I have is, so there's a hormonal contraceptive implant that goes into the arm. It's a little rod, kind of looks like a lollipop stick.
For women only, right?
Women.
Yeah.
All our hormonal contraception at the moment is only for women.
One day it'll change. Males will have to take them.
It would be good because at the moment, if a guy doesn't want to have a kid, his only choice is condoms.
Yeah, or vasectomy, right? Or
but that means no kids forever. You can reverse them, but it doesn't always work. So anyway, we had this patient come in. She'd gone to her GP because she wanted to have kids, and so she wanted this out. Now, usually these come out after 3 years. And the reason for that is twofold. One, because we can't promise that there is enough hormones in it still to keep you in contraception after 3 years. And the other thing is the longer a foreign body is inside your body, the more scar tissue it makes, the harder it is to get out. So she'd gone to a GP to have it removed, which is how most women get them removed. And he couldn't. So she came to ED. Now, she'd had hers in for 7 years.
Oh, that's a long time.
That's a long time, especially considering it's supposed to be 3 years.
Yeah.
So we had a super nurse or nurse practitioner. Same
Why is
thing.
it called super nurse? Is that...
well, super nurse is what they're called in my head because it's shorter than nurse practitioner.
Okay, all right.
But these nurses have extra training. They do suturing. They can do minor surgery, which is what this one was doing. They can give out a range of medications, including morphine.
Okay, so they're sort of like almost like a doctor, but not really.
Yeah, so different training pathways, different things. Nurse practitioners either go into one particular specialty or they go into procedural skills like ED.
Okay.
So this super nurse had an ultrasound probe out and was doing some minor surgery under local anaesthetic to try and pull this
I'm getting queasy already. I'm just imagining blood now.
So we've got the medical version of pliers, basically, a scalpel and an ultrasound probe, and he's just there pulling it out. I think it took him almost an hour to get it out.
Yeah. Oh my God.
By the end
were you just like trying to hold the hand down? Or?
Yeah. So the woman was okay. She just turned the other way. So I just kept talking to her because med students were very good at getting in the way, and we could also distract patients.
Yeah, which is probably better.
Yeah. So I helped out a bit with that, and then we had some other things that were coming in, like a patient who had some brick dust in his eye.
Okay.
Please, please, please put your visors down when you're riding your motorcycle. The helmet is good because it protects your brain when you crash, but keeping your visor down means you don't get brick dust in your eye. Because when you have brick dust in your eye, such as if you were following behind a trailer that had bricks on it, we have to scratch the brick dust off your eye with a needle. And if
my God!
Yeah. Now, I'm a female.
With a needle.
I'm supposed to be able to do this mascara thing. I really can't because that's like bringing something close to my eye, and watching me put contacts in is fucking hilarious.
Yeah.
But when you've got to stay still and we've got to take a needle to your eye to try and carefully pick this thing up.
Oh my God.
That's pretty terrifying.
So would you have to localize the eyes or something?
Yeah, so we put some eye drops in, which is an anaesthetic, so you don't feel anything.
But still you can see the
But
needle.
you can still see it. And you can't close your eyes because we need your eyes open. We can't put you to sleep because then your eyes are closed and we need them open. So you kind of just have to lie there whilst we have a needle to your eye. Yeah.
Oh my God, that is scary.
So please put your visors down.
Oh my God, I don't know what to do from here now. What are my questions now? Just in total shock. Have you been in a situation where you've been in total shock or anything? Apart from the one where you fainted.
Yeah, so there's bullying and harassment in medicine.
Okay.
And I think that's probably the most times I've been in shock. A couple of weeks ago, I had a patient tell me I was trying to put a cannula in, so a little tube into the vein to get medications. Yeah. And when you're sitting down in a chair, like when you get blood taken, it's really easy to go for the inside of the elbow. Yeah. And you just sit down and the person taking the blood kind of like leans over and all as well. Yeah. But this patient was lying in bed, so you can't really sit because you've got to try and get all the angles right. Yeah. So I tend to kneel. Mm-hmm. So I kneel, I can get all of my equipment next to me. For me, it's just really comfortable and it's easy to get the cannula in. Yeah. So this gentleman, older gentleman, not demented, not delirious this time, so no excuses.
So no drugs whatsoever. He's just come in and waiting to get his cannula.
You know, it's been a very long time since I had a pretty young girl on her knees in front of me.
I'm so sorry. I shouldn't be laughing.
Oh, well, it's funny in hindsight, but when you're there, you're completely frozen. I need to put this cannula in so we can give you the medications you need to treat you. Yeah. This is in your best interest. You have agreed to the needle. You don't have a needle phobia. Yeah. I'm really just trying to do my job, mate.
Yeah, I think when you're doing it at the time, it could be quite off-putting because you're like, hey, look, I'm a professional here. Yeah. Let's not go into these dirty jokes. But I'm sorry, but in hindsight, it's funny.
Kind of funny.
It's kind of funny.
But it's also not unheard of. One of my other female colleague medical students 2 years ago, almost the exact same comment.
As well. Yep. Cannula.
Putting a cannula in, kneeling whilst the patient was in a chair, and it's been a long time since I've had a young woman on her knees in front of me. Well, that's nice, but if I'm going to ask questions about your sex life, I just come out and ask them. I don't want to know about your sex life if I'm not asking. And you've already mistaken me for a nurse every single time I've seen you this week.
Yeah, it's like I'm trying to be a doctor so I can save people like you.
Well, nurses do a great job, but they're also two different skills. There are things nurses can do that I can't do, that I won't do. Yeah. I care about my patients, I do. Yeah. But I kind of don't want to sit there whilst they cry and tell them everything's going to be okay. Yeah. And nurses do some of that. Yeah. They also do amazing jobs nurses are the ones who really know about a patient's life.
The emotional support and
what's happening at home, etc.
Yeah.
For me, that doesn't really interest me as much.
Yeah.
So we have different roles. One is not better than the other.
Yeah.
It just, doctors have more medical knowledge, and so we often call the shots and make the plans.
Yeah.
But for example, if you're doing a wound dressing, we get no teaching about that in med school.
Yeah.
I will defer to my nurses almost always.
Yeah. Because, like, as a doctor, like, you got to sort of sometimes make hard decisions.
Yeah.
So I guess if you get too close to your patient and know everything, it might distort, some of the decisions that you should be making on a professional level instead of going, oh, but there's that factor. Yeah.
So part of it is you just get into an empathetic depression.
Oh.
You just get so burnt out that you kind of can't care anymore. So having a little bit of distance between you and your patients, it helps protect you.
Yeah.
It may not be the best thing for the patients, but it's something that almost all the doctors I've seen do.
Yeah.
And we also have professionality things like, I can't treat my friends or family unless they are literally dying in front of me.
Okay.
Which is possibly one of the times I wouldn't want to treat them, because if they do die, it's my fault.
Yeah. That's a tough one, talking about conflict of emotional interest.
So if we are too close to a patient, we can't treat them.
Yeah. It's all right. I won't ask for you then. And so from here, when you go to Wagga, what are you going to specialise in?
Yeah, so you don't get to choose your specialisation until 2 years after you finish med school.
Yeah.
So I'm thinking either anaesthetics at the moment, so the doctors who put you to sleep, or a GP anaesthetist, which means I work as a GP in a rural location and I do anaesthetics on the side in a rural location.
For a hospital?
Yes.
Or anywhere?
I can work anywhere, but usually it's a rural hospital, because if it's a city hospital, they've got fully fledged anaesthetists.
Yeah. And so being an anaesthetist, I've actually, apparently, this is what they told me after.
Yeah.
I've sung, apparently, when I've been in theatre.
Hope it was in tune.
Yes, literally in theatre I was singing. So is this a common case?
Yeah, so when you have an anaesthetic for a surgery or an operation, there's a couple of different choices we have.
Okay.
One is we can do like a local block. So that might be something like an epidural, like a woman has in labour. So you're completely awake. The rest of your body is not affected. It's just completely numb and paralyzed in one point. So we can do that for arms, we can do that for fingers, we can do that for legs, etc. So it's a really good option. Most patients choose no to that because they'll hear the screws and swords, and they don't want that.
Yeah, no, I wouldn't want that either.
So that's fully conscious. The next step down is what we call sedation or twilight anesthesia.
Sounds nice.
Yeah.
Twilight.
Yeah, less vampires.
Of champagne with that?
No, but less vampires.
Okay.
We do
sparkling vampires.
Yeah, so we give you this anxiolytic, which is a medication that reduces your anxiety, makes you a bit loose, which some of the anaesthetists do say, so here comes the bubbles, because it is like champagne. It makes you a bit like tipsy. Yeah. Lowers your inhibitions, lowers your stress.
Okay.
So we'll give that, and we'll give some pain relief so you don't feel anything.
Yeah.
And then the patient's like half asleep, so they might talk, they may move. So in those cases, we just keep everything really quiet so the patient doesn't wake up.
Okay.
So if we've got music on, the music's mellow, it's quiet. We're not playing any of the headbangers, etc.
So was that probably where I started singing?
Yeah, probably.
Okay, all right.
Either that, or you were having a general anaesthetic, which is when we completely paralyse the patient. But this was before you got to the general part. They would have just given you the bubbles.
The bubbles, yeah.
Before they got started.
Okay. And the general means you're completely zonked out.
Completely zonked out.
Yeah.
So in that case, the anaesthetist is controlling literally every aspect of your body.
Oh my God, that's scary.
Yeah. So they control your temperature. They control your heart rate, your blood pressure.
Yeah.
We make sure that your brain activity stays in certain levels, so you're not too awake, you're not too asleep. You're completely paralyzed, so we have a machine breathing for you.
Oh, wow, that's literally a cyborg now.
Yeah.
Relying on a machine.
Yeah, so the anaesthetist's job is to keep you alive whilst the surgeon
does his things.
Yeah.
Or her thing.
Yeah.
So then, if an operation, let's say, goes for 10 hours and you are the anaesthetist who has to watch over, so that means, what do you do? Do you just watch the whole operation?
Yeah. So If it's for 10 hours, there's almost always another anaesthetist around.
Okay.
So you do get breaks.
Okay.
We have to give you breaks because otherwise it's just not safe.
Yeah, I was about to say that.
Yeah.
10 hours is quite a bit.
And also, eventually we're going to have to pee.
Yeah, that's true. Yeah.
So
Health hazard.
Yeah. So all the anaesthetists I know are a little bit quirky. So they all have
What are you trying to say about yourself? You're a bit quirky yourself?
Absolutely, I fit in perfectly. They all have an obscure hobby. So one of them is one of 2 handmade kilt makers in New South Wales.
Amazing.
He makes his own kilts all by hand.
So Scottish background, I'm guessing.
Yes.
Okay.
Another one does ballroom dancing, so he'd show me videos whilst we were watching the patient, and he'd like show me a couple of moves on the corner of the operating theatre.
Literally, you are in theatre. Oh,
Dancing, yep.
Dancing.
Yep. Some bring their knitting in, some play Sudoku, some have Candy Crush or Angry Birds, whatever the flavour of the month is, on their phone. And the whole time, the anaesthetist will keep looking at the machines. We'll keep looking at the patient if we can see them, because we've got drapes everywhere.
Okay.
And the machine also has beepers on, so if anything goes out of whack, we'll hear it and we can see it.
What's your quirky side hobby?
So I spin wool, like with a spinning wheel.
Like out of Sleeping Beauty, where she's like spinning, that kind of.
Yeah.
But obviously not when you're in theatre, right?
No, because it's too much stuff to bring in.
Yeah.
So I probably just knittle something in theatre or read a book.
All right.
But clearly not an exciting book, because then I'll just read the book and not look after the patient. That would be bad.
Wow. And then the doctors themselves, the surgeons who are operating, let's say they operate for like 10 hours. Yeah. Do they change over as well, or?
Yeah, so surgery is a bit different because anaesthetics, different anaesthetists are very different, and every anaesthetist will have their own perfect cocktail for patients.
Okay.
It's one of the things I really like about anaesthetics is every patient, you change the amount of drugs and type of drugs and timing of the drugs for each patient.
Because of different weight and
different procedures, and each anaesthetist has their own favourite drugs, etc.
Okay, wow.
But surgeons kind of just don't let go. Okay. So usually when a surgeon operates, you've got the fully trained surgeon, and then you have the surgical registrar. So they're the one on the surgery training program. Yeah. And they're kind of working together. So they do need lunch. They may decide if it's a 5 or 6 hour procedure just to go straight through. Okay. So clearly they time their water intake before that very carefully.
Yeah, I never thought of this.
Yeah.
Because they can't just go and have a break and go, I need to go pee or something like that.
Yeah.
Wow.
If it's longer, then they'll make sure that they take their breaks in separate things. Yeah. So, that's kind of what they do there.
It takes a lot of coordination and preparation beforehand. Mm-hmm. Yeah, because I guess if, let's say, someone was desperately needing to go to the toilet, like one of the surgeons, because they'll have to, take all the scrubs off, and then they, like you said, it takes 5 minutes to wash your hands again to come back in. So let's say all that process, would that usually for a normal person, it'll be 5 minutes. For a doctor, it'll be half an hour?
Well, maybe not that long. Yeah. So it depends on where you are with the surgery. If the patient is actively bleeding and you need 2 people to control it, you can't leave. Yeah. If it's a more stable part of the surgery, you've got to step away from the patient. Maybe you have to find other people to hold the retractors so we can still see what we need to see. Yeah. So retractors are basically just these these sticks with a curve on the end of it, and we use it to hold the flesh open. Yes. Yeah. So you've got to make sure there's someone ready to hold those, which is usually the med student. Yeah. Very good at holding things. And then you step away. You then have to take your sterile gloves off, and there's 2 pairs of those, and your sterile gown off. You then walk outside the theatre and take your mask off. You then go to the bathroom, eat your food, and that might take, 10 minutes because they don't give themselves really good breaks. You come back, you then wash your hands again for 5 minutes. Okay, yes, right. Put your gown on, put 2 pairs of gloves on after you put your mask on, and then you go in. And then you're ready to operate again. That's a routine. It's good to have this kind of routine though. But, it takes time if they want to take a break. So you've got to plan it throughout the procedure. For example, I was working recently with a plastic surgery team, and we had a patient who came in who was a removalist. And when he was moving the furniture, he was moving a piano and he slipped. Oh, no. So Acme would tell me that having a piano fall on you is absolutely hilarious.
Yeah.
In the case of this patient, it means that one eyeball immediately popped.
What?
Yeah.
Oh my God. I just think like popped out of the eye socket?
Well, I was hoping... Well, not hoping. It was really bad that it happened, but I was hoping that when we opened the eyelid, there would just be like pieces of eyeball in there. You like pop. But it still looked like an eyeball, so that was a bit disappointing. I'm told that it enucleated or something, so basically he'll never see through that eye again.
Oh, no.
And because of the condition he came in, the entire front of his face was all smashed up.
Oh, no.
And when that happens, he couldn't breathe. And we couldn't put a tube down his throat either because the front of his face was disintegrated. So we actually had to do what's called a tracheostomy. So we had to cut a hole in his neck to get to his trachea so we could get him to breathe. Yeah.
Oh,
you know, when you press on it and you've got a Darth Vader voice? Yeah. That.
Oh, my God. That is intense.
Yeah. So he was in ICU for several weeks before we could operate.
Wow.
And when we got to the operation, that was like 10, 11 hours. The surgeons are switching in and out in between. And we ended up having to pull the piece of his nose out from between his eyes.
Oh, my God. I am getting queasy.
Yeah. We had the neurosurgery team on call in case we had to go from the brain inwards to push these things out. Because we weren't sure if we'd be able to pull it. We thought we might have to push it, which means neurosurgery would have to come in, open up the skull, get the brain out of the way and push it forward.
Oh, my God.
So, and the whole time he's still in ICU. We can't, he's under general anaesthetic.
The whole time?
Yeah.
Because he will be in so much pain, right?
Yeah. So much pain. So we don't actually know if he can see out of his other eye.
Oh, my God.
Because that got damaged as well.
Yeah.
But it's not an instant. Anatomically, we'll never see through it again. So we can't tell that. It was really tough.
So I'm guessing he wouldn't have been able to eat either.
No.
So how would he have been fed over that 11 weeks, was it?
He was in ICU at least 2 weeks before the surgery.
Yeah.
Yeah.
So how did he eat then?
So when you can't eat, we've got a couple of options.
Yeah.
So one is called a nasogastric tube. So we put a tube down your nose. Into your stomach and we push the world's grossest ever looking smoothie down that.
Okay.
Luckily you can't taste it.
Okay.
But when we put that tube down, you're gagging a lot.
Yeah.
We couldn't do that for this patient because his nasal bones were all smashed up and there is a very real risk that that tube could have gone into the brain.
Oh my God.
Yeah.
There's so much risk with this.
Yeah. So we couldn't do that.
Okay.
So I believe what they ended up doing is we can also do what's called a PEG tube, which is when we do a surgery in the stomach and we put the food immediately into your stomach.
All right.
And we also have what's called parenteral feeding, which just means it doesn't go through the GI tract, where we hook up a special gross smoothie
GI tract, which is
your bowels. It doesn't go through your gastrointestinal tract.
Okay.
So we hook up a sterile smoothie and we push it through your veins.
Oh, wow.
Yeah.
Look, this is all like new to me and really intense, and I am sort of getting queasy.
Yeah. Well, that's what happens sometimes. Like, there are some things that just make you queasy.
Yeah.
And doctors have the same thing. If you ask any nurse or doctor, there is one body fluid that they just cannot handle.
Yeah.
For me, it's saliva.
Yeah.
You get, like, I have to put my finger in someone's mouth and
don't want to do. Wow.
Like, one, they'll bite me, but also there's saliva and, like, tongues. They're so wiggly and, like...
And they got, like, little sand dust.
Yeah.
Like, you know, where you saw.
Yeah.
Sandpaper.
I can't handle saliva. Other people can't handle phlegm, so when you're coughing up stuff.
Oh my God, no, I don't think I can do that.
Some people can't handle snot. Some people can't handle, like, spinal fluid if it's leaking.
Yeah. Or blood, like myself. Yeah.
Not gonna lie, most of the nurses and doctors can handle blood because it's pretty common.
Yeah, I know. For me,
for nurses, if you can't handle urine or fecal matter, you're out.
Good thing I'm not in the healthcare, sector. I don't think I'll ever go in that.
Well, we've got positions as, like, wards people and stuff. So
I still have to see blood. I don't think I can cope with that. So maybe, like, most of the times, like, everyone's resuscitating me.
Yeah, well, that's one of the positions that our ward people help. If we have what's called a MET call, which is an emergency inside the hospital, we'll have ward people come because we can only do so much CPR before we tire out.
Yeah.
And it doesn't actually take that much skill to do CPR. So the doctors will all be doing the blood test, putting the tubes in, giving the drugs, and we'll have a ward person doing the CPR.
Yeah, you need like a whole team just in case, something goes wrong up here or there.
Yeah.
Well, you know what? Hats down to you, man. This is fantastic. I'm so glad I didn't end up doing medicine, but I'm glad you are.
Even though your parents didn't win Asian bingo?
My parents were Tiger Mom wanted me to be a doctor.
Yeah.
She pushed me so hard. It was either that or then become an orthodontist, and I'm like, no, I can't do that either.
Yeah, gross teeth and saliva.
Yeah. And I remember doing like, I think it was in high school where you had to do 2 weeks of work experience. And then obviously I had to choose dentistry because my mother pushed me to do that. Mm-hmm. And I literally had to walk out of the room when the dentist was pulling her teeth out because I couldn't cope with the blood.
Mm-hmm. Yeah.
But I'm glad there's people like you who are able to face it, and apart from the saliva part.
That stuff's just manky.
And so I hope all the best.
Thank you,
Wagga, and thank you so much for coming.
That's okay. Yeah. Thank you for having me. It was a lot of fun.
It was amazing just to learn everything. And I hope this will inspire a lot of youngsters, whether you're from an Asian background or from any background, with white tiger mums or normal tiger mums or tiger parents in general, that you're going to be a little more prepared now of what to expect.
Medicine's a hard yak, but if you can't think of doing anything other than being a doctor, it's totally worth it.
Yeah, and, contributing to society and helping people because we need more empathetic people. And also, we also understand that sometimes, I just understood from our conversation that you do need to step away from the patient, to build a bit of a gap because you'll be operating on them. So you can't get too emotionally close. Yeah,
and patients will die. We try our hardest not to, but patients will die.
Yeah. So it's inevitable because what happens when you go to hospital is because something's, you need to be fixed. Mm-hmm. And sometimes, it's not the doctor's fault or whatever. It's just, sometimes it's just fate that it's your time as well. And that must be really hard as well for young doctors coming on board to to understand that you have to let go.
Yeah.
Yeah. All right. Thanks, Elizabeth.
Very welcome.
Bagrat out. Hey, thanks for listening to this week's podcast. For the latest updates and posts, follow us on Facebook, Instagram, and Twitter. If you love it as much as Captain Bagrat and I do, please support us on Patreon, where we hope that our dream of having our own TV show will become a reality one day. So then we can continue to fight boring news on everything, anything, and nothing with an Asian twist. Thanks for your support. Bagrat out. Solid.